Hello friends, good morning. Myself Dr. Alpesh Sarvaiya, Associate Professor, Cardiovascular and Thoracic Anesthesia at Department at UN Mehta Hospital. Today we are going to learn of the Tetralogy of Fellot, Part 2. In Part 1 we have previously learned in a previous lecture about the Tetralogy of Fellot, Introduction, History, Etiology and Pathology, and clinical features and diagnosis, and management of palliative surgery and management of cyanotic spell and its palliative surgery complications in previous lectures. Echo findings and medical management of TOF, management of hypercyanotic spell we have already learned. We have learned about the palliative surgery at BT shunt and its post-operative management. Today we are going to learn about the corrective surgery of Tetralogy of Fellot. Corrective surgery is the ICR, intracardiac repair, ICR. The complete repair of TOF consists of closure of VSD and relief of the RVOT obstruction via the median sternotomy on CPB, cardiopulmonary bypass pump. It is ideally performed in the first year of life, usually 4 to 6 months of age. Some centers undertake the corrective surgery very early in a few weeks of life, but the outcomes benefits are unclear at present. Good outcome may still be obtained after the repair of the TOF in adolescence and adulthood, but there is an increased risk of intraoperative, perioperative morbidity and mortality, mainly due to increased bleeding and ventricular dysfunction in adult TOF repair. Now, the different approaches, different method to correct the intracardiac repair of the TOF surgery are transatrial approach. Trans-RA approach is taken to repair the VSD using the pericardial patch and using the repair of the VSD closure with the pericardial patch, and relief of the RVOT obstruction depends on the level of the obstruction. Ideally, the integrity of the pulmonary annulus has to be preserved if possible. There are different approaches to reduce the RVOT obstruction. Like the first approach is the resection of the muscle bundle in pulmonary infundibular via the transatrial approach or through the incision in the pulmonary artery. Second one is the RVOT patch, leaving the pulmonary annulus intact. This is valve preserved surgery. And third approach is transannular patch across the pulmonary valve. This relieves the valvular outflow tract obstruction. And fourth approach is the pulmonary valvotomy or valvectomy. Fifth approach is the patch can be enlarged to the distal pulmonary arteries. And sometimes this is the diagram showing the pulmonary artery patch on pulmonary artery, and right ventricle is enlarged. And sometimes the pulmonary conduit or homograph from the RV to PA may be required in children if there is a pulmonary atresia or coronary abnormality. Adequacy of repair is assessed by intraoperative esophageal echocardiography. In T, we have to check for any residual VSD and degree of the residual RVOT obstruction, or direct pressure measurement of the RV and LV. In the PRV-LV, and the RV pressure should be two-thirds of the systemic pressure. Now, anesthetic consideration of corrective surgery of the TOF. Specific considerations are mainly for the management of the CPB in infants, the management of the hypercyanotic spells during the perioperative period, and some considerations for the during the separation from the bypass, and post-operative complication like the RV dysfunction, chat, residual VSD or residual RVOT obstruction, and some types of arrhythmias are very common. Now, anesthetic consideration of the repair of TOF. General it is not different from the other routine surgery, routine cardiac surgery for infants. except it has to be scheduled early in the morning to prevent the prolonged fasting. Induction of the anesthesia is the same with midazolam or ketamine and or with or without the sevoflurane. Muscle relaxation we used in our institute is vecuronium, analgesia with fentanyl, invasive monitoring with the monitoring the central line, and arterial or radial or femoral arterial line. And esophageal echocardiography, TE probe has to be inserted, and routine anticoagulation with heparin 300 to 400 international unit per kg. Cross-match blood 2 to 3 has to be preserved, and blood products has to be preserved like platelets and cryoprecipitates may require in after the correction of the surgery. Antifibrinolytic drugs like tranexamic acid has to be used, and inotropic supports may require post-operatively, mainly milrinone with or without adrenaline or noradrenaline infusion. Now there are sometimes the in perioperative period, patient may go into hypercyanotic spells during the anesthesia, before the anesthesia, during the after the induction, during the surgical stimulation. For the prevention of we have to take some measures for the prevention of the hypercyanotic spells and how to manage the intraoperatively and perioperatively hypercyanotic spell. We can use the oral sedative pre-medication such as midazolam or chloral hydrate. Midazolam is used at 0.5 milligram per kg 30 minutes prior to the surgery, and chloral hydrate 50 milligram per kg 1 hour preoperatively. In a very brittle patient's drug has to be prepared in advance, and heparin has to be drawn up, and surgical team has to be ready, standby. Spell is presented with rapidly falling saturation in response to any surgical or other stimulation, and ECG changes suggestive of ischemia may occur, like STT changes, and BP may fall. Spell is due to the muscular spasm in pulmonary infundibulum, leading to worsening of the RVOD obstruction and increased right to left pulmonary, right to left shunt across the VSD. For that cases, we can use the adrenaline and dopamine are the pure are beta 1 agonist and increase the infundibular spasm and worsen the cyanosis by increasing the shunt across the VSD, and should be avoided in perioperative period in children with TOF. Phenylephrine and noradrenaline are better options than the adrenaline or dopamine because they are the pure alpha agonist and they increase the SVR and reduce the right to left shunt across the VSD and should be used to treat the hypercyanotic spells. Now, main measures to control the hypercyanotic spells during perioperative period are reduce the infundibular spasm, improve oxygenation, increase the cardiac output, specific measure to reduce the right to left shunt across the VSD and reduce the infundibular spasm. For that, we can increase the inspired oxygen, check the position of the tracheal tube. Fluid bolus may be given in 10 to 20 ml per kg. Fentanyl 1 mics per kg. Phenylephrine can be used 1 mics per kg bolus and 5 to 10 mics per kg, up to 5 to 10 mics per kg given. If repeated bolus required, then and central access we have the central access available, then start the noradrenaline infusion at the rate of 0.1 mics per kg per minute. Esmolol infusion may be considered to reduce the infundibular spasm, and dose is 25 microgram per kg per minute is starting dose. Now, cardiopulmonary bypass specific consideration in infants for the repair of TOF surgery. Intraoperatively and preoperative steroid treatment to prevent the inflammatory response to CPB is controversial and generally doesn't require for the sake of any infection. Pre-existing systemic pulmonary shunts are controlled prior to the CPB, like the BT shunt and central shunt has to be taken down to avoid the pulmonary hypertension. Cooling up to the 32 to 34 degree centigrade during the bypass, maintain the hematocrit during the bypass more than 21 and 30 before the separation from the bypass. Flow is maintained at the rate of 1.6 to 2.2 liter per minute per meter square, and transient reduction in the flow provide the adequate exposure during the surgery. Modified ultrafiltration post bypass to reduce the total body water and increase the hematocrit to aid the blood conservation. Prior to the weaning from the CPB, decision is made regarding the residual RVOT obstruction, and placement of the modification of RV outflow patch is required if the PRV-LV more than 0.8 or LA or RA pressure are more than 12 to 14 millimeter of mercury. If further correction is impossible, fenestration of the VSD patch to reduce the RV pressure, and sometimes the PFO also has been kept open. Often requires the inotropic supports following the surgery, like milrinone is ideal with or without the low dose of the noradrenaline to maintain the blood pressure. Keep RV well filled to minimize any residual RVOT obstruction. Electrolyte imbalance should be avoided, and serum potassium has to be maintained close to 3.5 to 4 millimole per liter to avoid any cardiac arrhythmias. Now maintain the normothermia, and bleeding should be controlled surgically, but blood products may also be required. Thromboelastography is ideal to use for the guidance of the blood products requirements. Heart block may occur as a complication of the surgery but is uncommon. Post-operative ventilation is required until the child is warm and well perfused, and there is a minimal bleeding. Most children have an uncomplicated course post-operatively and are discharged home within a week of the surgery. Now, some are the complication of the post-operative complication of the top surgery are mainly right ventricular dysfunction, residual VSD, residual RVOT obstruction, and some types of arrhythmias. We are going through one by one. First of all, right ventricular dysfunction. Right ventricular dysfunction may occur due to the cumulative effect of right ventriculotomy, inadequate myocardial protection during the CPB, residual RVOT obstruction. RVOT obstruction can be at the level of the infundibulum, valvular stenosis, hypoplasia or stenosis of the distal pulmonary arteries. Pulmonary regurgitation is also a cause of right ventricular dysfunction. It is mainly in the case of transcendental patch. Sudden reperfusion of the lungs and use of the cardiopulmonary bypass may produce the pulmonary edema on the basis of altered pulmonary capillary permeability. Other contributing factors to respiratory failure include the residual VSD and presence of large collaterals that can be managed with diuretics as well. And other factor is residual VSD to cause the right ventricular dysfunction. Now suspect the right ventricular dysfunction in top repair if there is a hypotension, raised CVP, liver is palpable, RV function is described as restrictive. RV function is described as restrictive since the problem is predominantly poor RV compliance. The restrictive physiology of the RV is called. It is due to mainly due to the systolic and diastolic myocardial dysfunction associated with difficulty in achieving the myocardial protection of the hypertrophied right ventricle. RV becomes stiff and unable to relax to accept the large atrial volume during the atrial systole. Restrictive physiology of the RV after trough repair is defined by the need of maintain to high CVP to maintain the cardiac output. Increased CVP cause the third space accumulation in the pleural and peritoneal cavities as well as the peripheral edema. Because of the low cardiac output, third space is not easily removed by the diuretics and may interfere with the mechanical ventilation and organ function. Clinically is diagnosed by the low cardiac output, slower post-operative recovery and persistent pleural effusion. Now, this is the echocardiographic Doppler echo wave, reading and wave specifically we can see in restrictive physiology of RV. There is an antegrade pulmonary artery flow in a diastole and typically recovers in 3 to 5 days. It is difficult to predict which patient will develop the restrictive physiology, but this is the more common in children with the severe RVOT obstruction who require the insertion of transcendental patch. The patient should be managed with adequate feeling, phosphodieters inhibitors like milrinone, inotropes, and other inotropes may require, that is described above. Diuretics and peripheral dialysis may be, peritoneal dialysis may required. Now, treatment recommendation for the phosphodiesterase inhibitor in TOP. It is recommended that milrinone be considered for any patient during the TOF repair to prevent the occurrence of the low cardiac output due to the restrictive ventricular physiology after TOF repair. It is recommended that milrinone be started for any patient with the right atrial pressure more than 50 millimeter of mercury or with the signs and symptoms of low cardiac output. The recommended loading dose of the milrinone is 50 mg per kg over 30 to 60 minutes, followed by an infusion of the 0.375 to 0.75 microgram per kg per minute. Now, the RV dysfunction is managed with the volume and optimize the RV filling, and RA pressure of 15 to 18 millimeter of mercury may be necessary to ensure the left-sided filling and adequate systemic outcome. Inotropic supports with dopamine or milrinone may require, maintain the AV synchrony, increase heart rate, either pharmacological or with pacing wires as usually required to improve the cardiac output. Ventilator maneuvers to reduce the pulmonary vascular resistance and may reduce the afterload on a RV, particularly in infants. Opening on the in infants we can keep open the atrial communication like PFO. For second one is the residual VSD. Residual VSD in operating room, if post repair pulmonary artery saturation is normal and T is performed, the likelihood of the detected residual ventricular septal defect is very low. The sutures securing the VSD page may tear, and unimportant left to right shunt may not be tolerated well in patient with poorly compliant ventricle and or pulmonary regurgitation. Hemodynamically significant leak will result in elevated heart rate and left atrial equal to or exceeding the RA pressure and PA saturation more than 80%. Findings such as this warrant investigation with the echocardiography, and early reoperation is required for the residual VSD. Now, third one is the RVOT obstruction. Post repair right ventricular pressure may be satisfactory when measured in the operating room, but RVOT obstruction may become more apparent later on. Moderate amount of the RVOT obstruction are often well tolerated in early post-operative period, but it is associated with the development of the ventricular dysrhythmias later on. The patient who has suboptimal post-operative recovery with high RV-LV pressure ratio may need to return the operating room. If a transcatheter patch was not performed initially, it should be considered for RVOT obstruction. Now, some types of arrhythmias are more common in TOF surgery, like complete heart block, right ventricular bundle branch block, junctional ectopic tachycardia JAT, and ventricular arrhythmias. Now, complete heart block is often transient, which occur in 3 to 5% of patients. Pacemaker system may be required if the CHB is persistent for more than 2 weeks. We have to wait for the 15 days or 2 weeks. Right bundle branch block can be expected on the post-operative ECG in all patients who have undergone the right ventriculotomy. Peripheral conduction across the infundibulum is slowed, and rarely does this represent the injury to his and Purkinje systems. The presence of left anterior hemiblock may lead to complete heart block. AV pacing should be used in this patient. Now, third one is junctional ectopic tachycardia, JAT. JAT is potentially a serious rhythm which usually occurs early in post-operative period. ECG reveals the AV dissociation with a rate high at 200 to 30 minutes per minute. A very rapid ventricular rate and lack of the atrial contribution to filling can produce the hemodynamic compromise, and cardiac output may be seriously affected. Now, management of JAT. How to manage the jet arrhythmias. The hypovolemia, anemia, and metabolic abnormality, if any, like hypokalemia, hypocalcemia, hypomagnesemia, should be corrected first. Induction of the hypothermia, or at least correction of the fever, suppresses the automaticity and may slow down the jet rhythm. This entails the use of the cooling blankets, ice bags, cold gastric lavage, sedation with Ventolin, muscle relaxation with vecuronium, etc. A decrease in a core temperature to 34 degree will reduce the heart rate to 150 to 160 per minute, and provided there is no metabolic acidosis. Metabolic acidosis, if any, has to be corrected. And reduction in catecholamines infusion has to be reduced, like adrenaline or noradrenaline. Atrial pacing to restore the AV synchrony, such as the override atrial pacings to induce the 2:1 block, and or paired ventricular pacing may be effective. Some medications we have used for the management of jets are digitalization, may lower the heart rate, amiodarone, IV or oral, procainamide or propafenol, propranolol and verapamil are some other anti-arrhythmic drugs we can use for the jet management. They slow down the heart rate or induce the second degree AV block, which slows the ventricular response. In extreme cases, jet is refractory, then emergent cryoablation or cryoablation for the bundle of haze. Sometimes we can use the ivabradine also nowadays. Ventricular arrhythmias. Ventricular arrhythmias may lead to late sudden death. It is usually the result of the re-entered ventricular tachycardia arising from the site of the ventricular tear. Patients with ventricular ectopy or residual RVOT obstruction are at the higher risk of ventricular tachycardia. Thank you. These are the main complications.